Good morning. My name is Dr. Rami, cardiac electrophysiologist here at Houston Methodist Hospital in Houston, Texas. This morning we're going to be doing a case pulmonary vein ablation on a patient with paroxysmal atrial fibrillation, 39-year-old lady with recurrent drug-refractory paroxysmal atrial fibrillation. She's here to have an ablation procedure done to eradicate her atrial fibrillation. So today I'm going to be discussing how we do our procedure to reduce our fluoroscopic utilization and how the cardio system allows us to do the procedure in a low fluoro environment with a effective workflow that allows us to predictably complete our procedure in a reasonable amount of time. So I start the procedure getting vascular access under ultrasound. I think that's really important, especially because the amount of blood thinners that we use during the procedure, we want to make sure that there's no vascular complications. So typically we'll go with a long 9 French sheath for my cardio sound catheter and directly place my Mobi catheter, which is a deflectable sheath. For most patients I will use a small curve. If their atrial size is larger, then I will use a large curve Mobi sheath. So after I get vascular access, I'll go ahead and give them a bolus of heparin. Typically I'll give them 100 units per kilogram. So at this point I'm going to go ahead and put up my sheets. So the cardio sound catheter is actually an 8 French sheath, but I'll usually use a long 9 French sheath just so I have a little bit of room for manipulation of the catheter. And as I stated, I go directly up with the Mobi catheter, which is my deflectable sheath. I'll kind of advance it as far as I think where the tip will go, but making sure that it goes smoothly. Just going to flush out the sheaths. I use a long sheath for the left side just to kind of help navigate across any vascular tortuosity so that we can advance our decapolar catheter, which is what I'm going to place on that side. Okay, so now that we got the vascular access, we'll kind of move on to the next step, which will be creating a 3D geometry of the chamber of interest. So in this case, we'll focus on the left atrium. So I'm going to advance my cardio sound catheter. So just to kind of show you, this catheter has the ability to deflect in an anterior posterior plane and left to right. Okay? And it gives you a fan view of your image. So I'm advancing it up the sheath, and I can kind of see as I'm navigating up if I'm obstructing any vasculature. So it should go up smoothly, and we're now going to enter into the right atrium here. So there's our right atrium. We'll now start off with creating some geometry of the right atrium. So this is a cava tricuspid isthmus. She has a very prominent eustachian ridge, and this is important in cases where we have to do a cava tricuspid isthmus flutter ablation. And then I'm going to clock it, and as I clock it from that home view, we see the aorta, and I will usually mark the non-coronary cusp on the aorta. And that's an important marker of where your AV node His-Purkinje system runs. And as I clock it a little bit further, you can see your left atrium. You see the fossa ovalis, you see the mitral valve, and you can even see a little bit of the appendage there.
Okay, grabbing some left atrium.
And then I'm going to clock it back a little bit more, and there, so we counterclock it, and we can kind of see the CS ostium there. See it almost as a cross-sectional. So I think this is a better view here, Zach.
Okay, grabbing that.
Yep.
Yeah, great shot there.
So we can kind of then use that as an anatomical marker to help guide our placement into the coronary sinus body. It's probably a little bit more of a longitudinal view. And then I'll usually kind of make sure that there's no baseline pericardial fusion, and we'll go ahead and store that image there. And then I'll deflect my sound catheter, advance it into the right ventricle, undeflect it, and then I'll clock it a little bit. And I'm doing this to basically get another view of the left atrium. So there's your left atrial appendage, and it's a nice view. You can see that there's no thrombus in there. In a patient like this, I wouldn't expect there to be any thrombus, but in more complex atrial fibrillation ablations, that's always something that you want to be certain of. You can also identify the LA ridge there, which again is important to know which side we are ablating on, whether it's the vein side or the appendage side. And now I'm going back to my home view, and I'm going to clock it. You see the aorta, and then you see, again, the fossa ovalis, you see the appendage, and you see the mitral valve. I'll clock it some more, and you should be able to come into view now are the left pulmonary veins. You see that superior right there? So that's a superior. And then I'm going to clock it some more. And you can see that this is your right inferior vein right here. And then your right superior up above that. And as we clock it more, you kind of see more of a cross-sectional view of that right superior on the left hand side, and then your right pulmonary artery on the right hand side. I'm going to counterclock it a little bit more. Let's see if we get a better view of our esophagus. I think this is a better view right here. So I'm going to leave that view up for a second here. And at this point, we've created a 3D geometry of the left atrium with all the appropriate anatomical markers in the right atrium. We've changed our catheter to the SmartTouch SF. This catheter allows us to deliver less fluid. It's a uniform heating of the tip because of the design of the porous tip of the catheter. We use this little sheath to protect the tip of the contact sensing portion of the catheter, and that's important that you use that sheath as you cross the valve of the sheath so that you don't damage the tip of the catheter. So you have the catheter, you know, it's still in the sheath because the electrodes are still black, and so I'm going to pull back on my deflectable sheath here, and now those electrodes are no longer black, so that means we're out of the sheath. And I'm going to go ahead and advance my catheter up. Again, there really shouldn't be any resistance. In most cases, it'll go straight up into the SVC. Once I go up into the SVC, I'll slowly bring it down. And as I'm bringing it down, Zach here is creating a map of the right atrium, a relatively rudimentary map, but it's useful just for our initial placement of the catheters and landmarks for our transseptal puncture. And so then we had made those initial maps of the coronary sinus ostium, and we're going to kind of use that as a road map to kind of go ahead and go into the CS. And you see it kind of lines up. It's almost like a bullseye that you can use to engage the CS. And now I'm going to park this up a little bit higher. So there's our decupolar catheter, and again, I use the long sheath because that kind of gets us around some of the vascular tortuosity. And so we can kind of use our map, and we can kind of slide our decupolar catheter in. There we go. So that's further out into the CS, and right now you don't see the catheter itself, but as we make geometry in that area, that catheter will come into the view. The next part of the procedure is the transseptal puncture. To do this with a reduced fluoroscopy, we use our map that we've created with the ablation catheter, and then we're going to use our cardo sound catheter, which is then going to help navigate how to position our catheter tip. So right now, on the cardo sound, we can see the fossa ovalis clearly. And if I look at my geometry on the right view and the left view, I can see that my catheter, ablation catheter, is above the quadrant of the ultrasound. So I know I'm up too high. And I also know that I'm a little bit anterior. So what I'm going to do is I'm going to deflect my sheath a little bit, and I'm going to put my catheter up in contact against the septum, and then I'm going to advance my sheath. And you can see all this on the sound. So I'm looking at this, and there clearly I'm engaging the fossa ovalis. Now, if you look at the 3D map, you can see that basically my ablation catheter is within that field of view of the sound catheter. So you confirm, you know which way to go, whether it's anterior or posterior, whether you're too high or too low, so you can utilize that to accurately engage specific anatomic structures. And that's one of the nice features of this system, is that it's integrated into the 3D map. So the green tip overlay shows you that your catheter of interest, which is the ablation catheter, is actually within the field of your ultrasound. So basically that's telling you that your tip of your catheter is right there. So again, it's important to know that you can actually directly visualize the tip of your catheter. And so now I'm going to advance my sheath up, make sure I'm happy with my transseptal spot. And then at this point, I'm going to go ahead and withdraw my ablation catheter. And my sheath now is engaged in the fossa. So now that I'm engaged on the fossa, I'm going to place my Mobi dilator along with the transseptal needle. I'm going to flush the needle as I'm advancing it. And then I think what I found helpful is that we try to keep that bevel on the transseptal needle fixed towards the screen. I'm watching my ultrasound continuously as I'm advancing it, and at some point you'll see that the sheath starts to kind of come off the fossa. So that means our dilator is up, and so at that point I will fix my dilator and pull my sheath back towards the dilator, like that. And now we have a good amount of tenting, and I'll advance my needle, confirm that we're still tenting well. Okay, let's go ahead and come on. All right, and then we crossed into left atrium there, and you see that tenting is gone. Now I'm going to go ahead and advance it. Keep my dilator fixed, and then just kind of proceed the way you would with any other sheath placement here. And we're across into the left atrium now. So at this point, we'll use the Pulmonary catheter. The Pulmonary catheter has 5 splines, and the electrodes are relatively small. So that enhances the signal quality, the fidelity of the signals. It's a unidirectional catheter. The spacing can be 2.62 or 4.4. We usually try to use a 2.62 as you can get closer bipoles, and again enhance your signal quality in that way. There's actually 2 proximal electrodes to it on the back wall of the shaft as well, and that kind of needs to be outside of the sheath in order to localize the splines on the catheter. There's a central lumen that needs to require continuous flushing, so that's flushed right now. And then I'm going to go ahead and cover the splines of that catheter, and then again use that to engage into the deflectable sheath. And you can visualize on the sound catheter as your catheter is being advanced, and of course it's on the 3D map. And just like with the ablation catheter, if it's inside the sheath, those electrodes are going to be black on the 21 and 22. And here it's coming out now. Okay? So you can see my splines there. And what I will usually do at the beginning of the case is I will create a 3D geometry of the left atrium, pulmonary veins, the appendage, and I'll take a voltage map at baseline as well. And we can do this relatively quickly. So that's going into the left superior, and you can kind of visualize very well on the sound catheter, when you're near the ostium, near the carina. So it makes a very nice map. And now we're engaging the left inferior. So that's your inferior there. And I'll spend a little bit of time just making sure we have a very nice anatomy of the veins. The maps that we create are real time, and they're very accurate to the point where we've reduced our need for CT imaging. So now I'll just create geometry, and as you can see, we're quickly collecting points off all the electrodes. And I can see that my catheter is going up the right superior there. And now we're going to engage, and you can see actually on the sound catheter there's actually two branches on that right inferior. There's a small branch that goes a little bit more superiorly, and then there's a bigger branch that's much more inferior. So again, that's helpful in making sure that you don't miss any of the branches off those pulmonary veins. The catheter itself allows you, as you're doing the mapping with the confidence system, it allows you to collect points that are actually not internal but measure more towards the surface of that cardiac chamber. So that makes sure that, again, that your map is accurate. And again, you can confirm that using the sound catheter to make sure that you have good contact. It's also nice to have the ability to validate that with another parameter. So when we look at how the points are collected with the confidence system, there's several different factors that it uses. You can, and this is something that's completely tailored to what your needs may be. So you can instruct it to collect points only within a certain cycle length, when it has a certain amount of contact, when there's stability in the catheter. So I usually deflect my sheath at this point, and that then kind of allows me to get to the floor and then get up against the septum without having to worry about losing my transseptal access. And you can see on the sound catheter that we're touching our septum very well. And we're kind of coming around now, and I will release some of that sheath deflection. Okay, and then it popped into the right inferior. And now I'll kind of complete my map of the anterior wall, left atrium. So I think that's a pretty good map. Pretty healthy signals. And at this point, what I'm going to do is go ahead and engage my Pulmonary catheter back into the veins. Other than the signal quality, the other aspect of the Pulmonary that's nice to utilize is actually rather easy to engage the veins. You can also sometimes engage both veins, the inferior and the superior, at the same time with the splines laid across both them. So it makes it a lot nicer, and of course the signal quality, as I've already mentioned, is nice. So at this point here, I'm going to go ahead and advance my Moby sheath. I have the Pulmonary in the left superior vein. I'm going to advance my Moby to cover the proximal electrodes. So that way I know that it's far enough engaged into the left superior pulmonary vein, which will be important when I exchange that sheath. I'm going to put up a second sheath now and cross into the left atrium using our previous transseptal puncture and a guide wire as a marker. So the preface sheath has a valve on it. It allows the introducer to engage the sheath much easier, which again ensures that the tip does not get damaged. So I've moved my preface sheath up to the level where my Moby sheath is, the transition point, and I can see my transseptal clearly on the sound catheter. And I'm going to go ahead and put up my sound fan so that we can then see how we need to manipulate our catheter. I'll now engage the preface sheath with my STSF catheter. So I know I'm out of the sheath, I'm in the right atrium. I can actually see my ablation catheter. It's right there where I need it to be. So I have my Moby catheter covering the proximal electrodes of the Pulmonary. So I know it's well engaged in the left superior. I'm going to go ahead and take out my Pulmonary catheter at this point. And now I'll advance back up with the Moby dilator and wire. I'll stop short of advancing it completely, and then I'll go ahead and pull back my Moby sheath back towards the dilator. And then I'll visualize on the Cardo sound. I can see that there is my wire. And go ahead and fix my wire. So now the dilator and sheath are just in the right atrium. So I'm going to clock it. So there you see it smoothly goes across into the left atrium. Okay? And then I'll go ahead and advance my preface sheath up over. You can see that. And then I'm going to go ahead and advance my Mobi back over as well. So there we go. I got it across. So now both my sheaths are in the left atrium. And now I can see that my ablation catheter is in the mid-chamber of the left atrium. I go ahead and advance it just a little bit there. Okay. And then I'm going to go ahead and advance my sheath over until I cover the black electrodes, until I get black electrodes. So now I know that the preface sheath is well within the left atrium. I'm going to go ahead and pull it back on the ablation catheter. At this point, we're going to go ahead and flush the preface sheath. Flush my Mobi. I'm going to advance my ablation catheter up via the Mobi deflectable sheath. Okay, we can see it coming up. We still see it in the sheath, and there it should be outside the sheath. And you can see it right there on my sound. And I do this because I want to clearly visualize that it's not touching any chamber before I zero the tip of my catheter for the contact. Ablation's at 16, 0 there.
Just inside the sheath. That's just out, perfect, and we're at 0.
Perfect. And now I'm going to go ahead and re-advance my Pulmonary catheter. Okay. And that's in the left upper there. With the SDSF catheter, I'll use anywhere from 35 to 42 watts in the left atrium. That is not the posterior wall. On the posterior wall, I usually limit it to 25 to 30 watts still. You can see that the tip itself is giving us contact. And typically I like to have at least 5 to 7 grams of contact. More importantly, it also gives us a vector, so you can see how the tip alignment is. And then we can use visit tag settings, so we're no longer just marking areas because we burned for a given area there. We're actually going to make sure that we have good contact force, good stability for a set period of time. So we're going to start ablating. Power of 42, please. Let's go ahead and ablate, please. And you can see that the signals immediately start to diminish, and you can follow that clearly as we're ablating. Clearly we're impacting the tissue here. So the icon on the left there shows you our time right now. As we're moving to a different location, it tells you your stability as well. Right now we don't have the stability, and there we've achieved the stability and met the criteria. So as soon as you have a time there, it means that you've met all the criteria that you've set for force, stability, and duration. So as you're ablating, you can see the signal quality much better. You don't have as much noise as you're ablating. So again, the vector tells us that we're kind of pointing our catheter in the direction that we want. You have the good contact on there. In the top left-hand corner, you can also see a zoomed-in view of your catheter, and I utilize that to kind of direct my deflection. If you notice, the catheter tip is color-coded, and so the red corresponds to the D curve, and then the blue, which is on the other side, corresponds to your F curve. And so that kind of helps in knowing how to manipulate your catheter depending on how you want to orient your tip. The handling of the STSF catheter definitely has better torqueability. You can see that I'm able to move my catheter with ease in the areas that I want to stay within. It's not as stiff, it's much more responsive, which all translates into an improvement in our lesion application. Ablation off. So now, I'm going to start up that posterior wall there. Let's go ahead and come down to 30 watts, please, and ablate. My rationale for using lower powers on the posterior wall is obviously we're concerned about the risk of esophageal injury. I believe one way to mitigate that risk is to use lower powers, lower duration, and close monitoring of our temperature rises as we're ablating along that posterior wall. Off. So typically I'll use power settings of 25 to 30 watts and try to limit it to no more than 8 to 12 seconds on that posterior wall. Ablate. Off. I'm on that posterior wall now. Ablate. Off. So now I'll move to a different area since we saw a temperature rise down there. So if you notice, there's smaller lesions kind of around the larger, more circular ball-like lesion. Those smaller lesions are kind of indicative of how the catheter kind of swipes through that area. Off. So in some cases, you can have a better idea of where your gap may be if you look at how those lesions are spread apart, and if there's ablate, if there's a clear gap where your catheter is not swiped while you're ablating, that's probably more likely to be an area of interest for you to identify a gap. Okay, show me AP roof, please.
There's AP on the right, pulling you down a little bit.
So I'm going to advance my pen array just a little bit so I can get it out of the way. So our contact is good. Impedances always seem to run a little bit higher along this area here. So the vector has utility here, making sure that we're more on the vein side and not on the appendage side per se as we're ablating. So we want our vector facing more towards the appendage as opposed to the vein. Okay, ablate. So it's kind of nice to visualize directly that we're on the right area. And I'm watching on both the 3D map as well as my sound to make sure that we're not flipping into the left atrial appendage. So what's our earliest signal here right now?
Maybe 1920 by a couple milliseconds, but they're pretty activating almost all simultaneously. Everything's anterior, 1718, 1920.
So I'm gonna just apply a little bit more here, and then I'll pace from the appendage and make sure we're not this far field per se.
Yeah.
And ablate. Off. Okay, let's see what we find when we pace from the appendage. Okay, so that's clearly in the left atrial appendage. And I'll pull my pen array catheter back. Make sure we're not too deep in the vein there. Okay, can we pace from the ablation distal, please? At 600. Okay, that looks good. It pulls it in. So that looks good on the left superior. And I'll just pull back a little more proximal, make sure we're not missing anything. But, okay. So I think that left looks good there. Pacing off. Let's verify that the inferior is also good.
Heading out that lower.
And looks like you have something there.
Yeah.
On 1-2, which is where?
Yeah. It's
1-2, we had something and then it's gone. So 17-18.
Right, and that was
That's
so 1-2 was inferior. That was earlier or earliest, and then 17-18, 19-20 is carina, anterior aspect of the carina.
Okay.
That signal right there, sitting right in between 17-18 and 19-20 with ablation distal.
Okay, ablate. Okay, I think that got it. Yeah. So clearly we can trust our map. We know where we need to go, and having that accuracy is important. Off. Okay, so that left inferior looks clean. Okay, I'm going to go over into the rights now. Let's start here. We'll go to 30 watts.
Okay, go ahead.
And ablate. So sometimes if we're having difficulty visualizing certain structures, you can even cut out a portion of the structures to visualize it better. So in this case, like the veins, Zach can cut out the veins and can then kind of see our catheter a little bit better, kind of get an idea where the ostium is. Kind of see our signals go away and attenuate. Off.
Just gonna move around a bit in this left view. And then I'll do the upper as well, real quick. All right, just PA on the right, and right lateral on the left. Hold up.
Okay, and let's ablate here. Off. Okay, let's go to 42, please. Ablate. Just pull back my pen a little bit so I can see the more antral signals there. And it's kind of nice, again, using the vector to know that you're kind of on the vein side a little bit there. The right, nice contact. Just kind of reinforcing the fidelity of the signal quality. It's really nice on the tip of this STSF catheter. Of course, we're ablating a much higher power, but the fluid that we're giving is really just half as much as we would normally give at these powers. And that makes a big difference for some of these patients. We don't routinely use Foley catheters anymore. Patients that have a predisposition to volume overload, we are less concerned about the risk of having volume overload or heart failure symptoms. And this was a significant problem previously. We'd either have to limit the amount of power that we give, or we end up having to give them a lot of diuretics after the procedure. As you can see, with the reduced usage of lead, our staff is much more at ease. Everybody's less drained overall. It's nice to go at the end of the day and not feel like you just lost a battle wrestling a bear, your neck pain. And personally for me, this is kind of where the quest for reduced fluoro came from, is that I was having a lot of orthopedic issues with my neck, my back. Couldn't imagine carrying on like this. So I made that a goal, and having these tools available for us with this system definitely helps to facilitate that. Ablate. So at the end of the case, after we've isolated the veins, we're going to just validate that by doing a voltage map and ensuring that everything is clean. You have something there. Where are those at? Where's 7-8 at 11, 12?
7-8 is inferior, just kind of inferior aspect of the vein.
All right, let's just clean that up then. Ablate. Okay, off. Okay, so again, that's in the vein, that's clean. So again, we're going to pace from the appendage, make sure that it's not far field signals. And I think we're kind of facing our left veins there. Yep. So go ahead and pace from my ablation distal, please. And there we have capture. Okay, so you have something, well, looks like it kind of pulls in, but you may have something in 17, 18.
Yeah, it's right on the edge of our line here in this left view. It's there at 17, 18 flipped up, and 17, 13, 14 should be more advanced past our line now.
Okay, so everything is within our lines right now?
Yes.
Okay, and looks like it's clean. Okay. Where's 13, 14?
That is right on the roof here in this left view.
Okay. All right. Looks clean. 13, 14, is that just on our line, or?
Yeah, with respiratory, it is Just on our line.
Okay. All right. Pacing off, please. It's a nice thing about the pen array is you can kind of, if you advance it in a little bit, you can kind of reposition your splines. It's a lot easier to manipulate than circular catheter in that respect. Okay, so everything is sitting in well.
Yep, everything's sitting in there.
Okay, and everything is kind of facing forward. So pace again. Okay, and it looks clean.
Yeah.
Looks good, right?
Yep.
Okay, good. Pacing off. And let's check our inferior. Can we get isopro ready, please? Okay, and that's our inferior.
Yep.
And let's pull back a little proximal there. Okay, so that's sitting good, and that looks clean.
Yep.
Okay, so our veins are done, and now we'll check with isopro and make sure that there is no reconnection. Can you pace for my ablation, please? Okay, that's good. Exit block. Pacing off. So we're just going up in incremental doses of our isopaternal. We're at 10 mics per minute per now. We're going to go up to 20 mics per minute. We'll look to see if there's any reconnection or any other additional triggers. Okay, so this is, we're just going to double check here. This is your left inferior, still good. It's pretty good. So we already confirmed that those were far field before. And here's your right superior. Okay, so that's, everything is in there.
Yes. Looks good. I think that's our, I would imagine still our far field SVC.
Okay. So that actually looks good.
Yeah, and this is where we did have signal before. Kind of where, what is that, 7/8, 1920 is at. So
Okay.
I think we took care of it with those lesions.
And we can turn off isopro now. Okay, so that completes our procedure. Looks like we isolated all the veins, gave the patient isopaternal, and no reconnection, no other induced arrhythmias, and high dose isopaternal.